Hello. Good evening, everyone. I am Dr. Anoop Velayudhan, Scientist T at ICMR headquarters. Many thanks and welcome to this first of One Health series webinar. The first webinar is conducted on Nipah virus disease. It's our proud privilege to welcome you to this series on One Health. We will be taking the webinar on different aspects of One Health, common diseases connecting human, animal, and the environment. With a very warm welcome, let me hand over to our head of division, Dr. Nivedita Gupta, to give the opening address, please.
Thank you very much, Dr. Anoop. And it's my proud privilege to welcome all of you to this first webinar on One Health that Indian Council of Medical Research has jointly organized with support and collaboration from CDC India as well as CDC US. We are very grateful. As you all know, that after a series of epidemics and pandemics that we have faced in the past 2 decades, especially starting with SARS, avian influenza, H1N1, swine flu, followed by Ebola, Zika, MERS, and now SARS-CoV-2. So repeatedly, these epidemics and pandemics have made us realize the very critical importance of One Health. But I think none of us has yet imbibed that approach of working in a One Health collaborative perspective. So now in India as well as globally, there is a lot of effort to collaborate with all the partners and come together with a very joint collaborative One Health approach. And the Indian Council of Medical Research is also embarking on this approach. And very recently, a national center, rather and upgraded to an institute now, National Institute of One Health, has been inaugurated by the Honorable Prime Minister of India and is now upcoming at Nagpur in Maharashtra in India, wherein 13 different departments of the government and working under the aegis of the Principal Scientific Advisor, again to the Honorable Prime Minister of India, will come together under one roof, under this National One Health Institute, and work together to holistically address the human, animal, and environmental health. So we have taken the importance of One Health and working on a One Health perspective very, very seriously. And starting from that, today is the National One Health Day. And that's why we thought that we would start this series of webinars, starting with the first one. And you would see that here in this webinar, we have very, very eminent speakers from across the world. And we have a blend of virologists, ecologists, clinicians, and epidemiologists. And again, it's my proud privilege to welcome all of them to speak here and kind of enlighten us that in the perspective of Nipah virus disease, how these different domains are interconnected and how important it is to holistically conduct research, surveillance, as well as develop medical countermeasures to very holistically address this problem. As an example, we have taken Nipah virus disease, but it actually cross-cuts against many, many pathogens, many, many organisms. So with this, I would again welcome all the speakers and all the attendees to this very important discussion on the Nipah virus disease and One Health perspective. And I would like to welcome the first speaker, Dr. Jonathan Epstein. And Dr. Jonathan Epstein, just giving a brief introduction of this very eminent speaker. He's the Vice President for Science and Outreach at EcoHealth Alliance, which is a science-based NGO in the New York City, USA. He's a veterinarian and an epidemiologist, and his research focuses on circulation and spillover of zoonotic viruses that impact both animal and humans, particularly those which are associated with bats. And he has conducted path-breaking research on Nipah virus disease, Ebola virus disease, and many emerging coronaviruses. And he has really improved our scientific understanding on the spillovers, transmission, and kind of infections that are harbored by the bats. And he was also a part of the team that discovered that bats are the reservoir of SARS-CoV, that is the SARS coronaviruses in China. And in 2012, he also identified that MERS coronavirus is also found in bats and camels in Saudi Arabia. So with a big round of applause, we welcome Dr. Jonathan Epstein to kindly deliver your very, very much awaited talk. So over to you, Dr. Epstein.
Well, thank you very much, Dr. Gupta. And it's such a pleasure to be here. I want to thank ICMR and the Indian and US CDC for organizing such an important meeting on One Health Day. And I am really grateful for the government of India's commitment to One Health as we move forward to develop systems for preventing pandemics and protecting human and animal health. So it truly is an honor to be here. Today, I'm going to share some insights on the ecology of Nipah virus, most of which we've gleaned from work that's been conducted next door in Bangladesh and a little bit in India, but really just to paint a picture of why it's so important that we pay attention to viruses like Nipah virus. And I think Nipah virus really is an excellent example of why we need a One Health approach to understand these complex systems that involve wildlife reservoirs, zoonotic viruses that impact domestic animals as well as people, and particularly a group of viruses like the Nipah viruses, of which Nipah is included, that have such a broad geographic range. So to just give an overview of why we pay so much attention to Nipah virus, which on the surface seems like it has a relatively narrow impact in terms of the geography where human cases have been identified. But in reality, this is quite a broad group of viruses. And I want to just begin by saying we should probably think of Nipah virus not as a single virus, but really one of a group of viruses. It's within the genus Henipavirus, which is a group of paramyxoviruses, but we know that there are multiple species of Nipah-related viruses that have the potential to cause human disease. And we know so little about the full genetic diversity of these viruses, but it's one that has the potential to be very broad and is worth paying attention to. What we know so far about Nipah virus in particular is that when it gets into people or domestic animals, it has the potential to cause significant disease and high mortality rates. So this is one of the reasons why it's been a WHO priority in terms of developing countermeasures and strategies for prevention. Nipah virus is really an emerging zoonotic virus in that we've seen it pop up in a limited number of places, India, Bangladesh, the Philippines, and Malaysia, where it was first discovered. But we now know that the bats that carry Nipah and related Henipaviruses have an incredibly broad geographic range, which means there's the potential for spillover to occur in other parts of the world, including places where there really isn't great surveillance and we might not notice it if outbreaks occur. But what we've seen so far where we do have good surveillance systems, such as in India and Bangladesh, is that we've seen repeated spillovers into human populations. And why that's a particular concern is that with viruses like Nipah virus, in general, RNA viruses, every time they jump species, every time they spill over from their natural animal reservoirs into people or other animal species, there's an opportunity for evolution or for genetic mutation. And each time that happens, there's a potential for a strain that might already be predisposed to more efficient transmission among people to emerge from its animal reservoir. So each of these outbreaks is an opportunity for a new strain of a Nipah or Nipah-like virus to emerge, a reason we really have to be paying attention to these viruses. And as I mentioned before, Nipah and related viruses are associated with a high case fatality rate. So when they do get into people, although so far they don't transmit very efficiently, we see mortality rates of anywhere from 40 to 70%, sometimes 100%, depending on the outbreak. And we don't have a treatment or vaccine yet. And I put yet in there because currently there are multiple vaccine candidates that are being developed and tried under the CEPI initiative and other initiatives. And so that's really important progress in terms of protection. But of concern is that there really is limited surveillance, and based on the geographic range, which I'll show you in a minute, of Nipah virus hosts, there really is limited health infrastructure and surveillance in many parts of the world where we know that the bats and the viruses they carry occur. And so we need to broaden and strengthen our surveillance to make sure we do notice when outbreaks happen in either human or domestic animal populations. And we have just begun to scratch the surface, really, in understanding the genetic diversity of Henipaviruses. And even within Nipah virus itself, we know there's a genetic spectrum of Nipah strains and variants, each of which may have a slightly different clinical and epidemiologic profile when it emerges in people. Just to show you what we understand so far about the range of the bats that carry Nipah and related Henipaviruses, we largely think about these viruses in a South and Southeast Asian context. But the truth is, Pteropus bats, which are a large species of frugivorous bats, exist throughout South and Southeast Asia, into Australia and the Pacific Islands. And then there are related bats in the same family that occur throughout the African continent. And there have been Henipaviruses identified in multiple species of bats across this very broad range. And that's the reason I say that it's so important that we really strengthen our surveillance systems and begin to pay more attention to this group of viruses, because we're good at noticing outbreaks when we have surveillance set up, as in India and Bangladesh, but we have no idea about how often these viruses actually do successfully spill over into different communities and in different contexts in different parts of the world. So focusing now on the South Asian context, where we have most of our experience with Nipah virus, we've seen almost annual outbreaks of Nipah occur in Bangladesh. And more recently, more frequent outbreaks are being noticed in parts of India, particularly southern India and Kerala. In total, we're seeing in Bangladesh since 2001, more than 320 cases, and they've been associated on average with a 71% case fatality rate. Again, very high when you consider comparable viruses. Ebola, on average, about 50%, although it can spike as high as 90%. MERS was 30%. And so these are very high case fatality rates. But fortunately, so far, when Nipah gets into people, though it is capable of human to human transmission, they tend to be limited in terms of how many generations of transmission we see, which is fortunate for control. But the real concern is that there may be strains of Nipah circulating in bats currently that have the ability to more efficiently spread among people. What we know about spillover, primarily from work in Bangladesh, is that date palm sap there is a primary route of transmission. In fact, almost exclusively, spillover occurs through the contamination of date palm sap, which I'll get into in a minute. And then once people get infected, they're capable of infecting other people. In India, the history of Nipah virus goes back also to 2001, where there was an outbreak in Siliguri that was hospital-based. But we've seen outbreaks in West Bengal and Nadia in 2007, and then more recently in Kerala in 2018, 19, 21, and as recently as this year. And we've seen hospital-based transmission. That was a feature both in the Siliguri outbreak in 2001 and in the Kerala outbreak in 2018. We know that the primary reservoir for Nipah virus in South Asia and the Indian subcontinent is Pteropus medius, or the Indian flying fox. This is a really common, abundant, large frugivorous bat. It's the only species of Pteropus bat that's present throughout the Indian subcontinent. So there are other species throughout Southeast Asia, but Pteropus medius is the only pteropid bat in Bangladesh and India, Sri Lanka, parts of southern Nepal and Pakistan. It's considered the major reservoir for Nipah virus, although Nipah has been detected in other species of bats. Some great work done by my colleague, Dr. Yadav, who's on the webinar today, and she may talk about some of the other detections in other bat species. Just to give you a sense of what we understand about Nipah virus ecology is that this particular bat, Pteropus medius, is a major reservoir. The virus has been isolated multiple times from this bat and detected throughout its range. This is a relatively common and abundant bat. In fact, it's one you might easily see living in the trees around your house, in urban centers or in rural villages. It tends to live quite happily among people. It's a generalist in terms of its diet. It eats a wide variety of fruits and is also a really essential pollinator and seed disperser, like so many fruit bats. So in the course of foraging throughout the evening, it will pollinate trees, help support our crops, and also drop seeds from fruits that it's eating. And this bat, like other types of wildlife, is very adaptable to humanized environments and in fact prefers fragmented forest landscapes. So it lives quite happily in tall hardwood trees that might be within a village, around cultivated fruit trees, even in botanical gardens and urban centers. So it lives in very close association with people and shares a lot of the same food resources with people and livestock. So it will happily eat mangoes or guava or lychee, bananas, a lot of the things that we grow to eat ourselves. And this could be a source of contact or interaction with people. In a study we did in Bangladesh looking at Pteropus roosts across the country and comparing roosts within the area of Bangladesh where most human outbreaks have occurred historically versus other parts of the country, we really did see that Pteropus bats prefer fragmented forests rather than large tracts of intact forests, such as in national parks, showing that this bat really is well adapted to humanized environments. And one of the really important concepts that's emerged from our studies of Nipah virus, both in Malaysia and Bangladesh, is this concept of wildlife provisioning. As I mentioned in Bangladesh, one of the key epidemiologic features of most of the outbreaks, if not all of them that have occurred, is that date palm sap has been a major route of transmission. And in Bangladesh, and this is true in parts of West Bengal as well, cultivation of date palm sap is a customary practice where people carve the bark off palm trees and allow sap to flow down the trunk into these clay collection pots. This juice is really sweet. It's collected overnight, and fruit bats have learned to exploit this as a food resource. So as you can see from these infrared images, they'll come in and feed off the sap stream overnight. And we know that Nipah virus is excreted. It's shed in bat saliva, urine, and feces. So in the process of feeding on this date palm sap, bats will contaminate the sap flow with saliva or other excreta. And occasionally when bats are shedding Nipah virus, which isn't often, but when it happens, they may contaminate a batch of date palm sap with virus. And that is when people get infected, when they drink this fresh in the morning or even ferment it. The virus is able to withstand the fermentation process. And the other point I wanted to make is that date palm sap specifically is a food resource that these bats would never ordinarily have access to. They are not equipped to strip the bark off trees to get at the sap. So this is a human provided food resource that these bats have learned to exploit, particularly in the wintertime when there's little other fruit available for them to eat. And what we've learned about Nipah virus distribution in Pteropus medius in Bangladesh is that this is a virus that circulates widely across the country. And as we're seeing, the same is bearing out to be true in India, that different populations of Pteropus medius are showing the presence of antibodies against Nipah virus, which shows us that they are a natural reservoir, that this virus is circulating normally in these bats. The incidence of infection, meaning how frequently bats are infected, tends to be very low. Only about 1 to 3% of bats are infected at a given time, but there's high levels of high percentage of bats in a population with antibodies, anywhere from 20 to 60 or 70%, showing that this is a virus that commonly circulates among bats and across broad geographies. We also saw that bats are capable of shedding virus throughout the year, and that points to the importance of having a route of transmission, such as date palm sap, that might be seasonal in the case of Bangladesh, where it's only harvested in the winter months, and that tends to coincide with human cases. Although it's possible that outbreaks could happen at other times because we've seen these bats shedding in the summer as well. And we conducted a 6-year longitudinal study, and I just wanted to share a couple of insights from that. Over this period of time, looking at a single population of Pteropus bats, we saw that there were significant fluctuations in the seroprevalence, or the proportion of bats with antibodies against Nipah virus. And that showed us two things, really. One is that over time, adult bats lose humoral immunity. They lose titers of anti-Nipah virus antibodies. And when that happens at a population level, we think that that population dips below a certain protective threshold or herd immunity, which makes that particular bat population susceptible to a Nipah virus outbreak. And it's when an outbreak happens within bats that they're more likely to be shedding virus, and when spillover to humans is more likely to occur. When we modeled these serologic data, we found that adult bats are really driving the circulation of Nipah virus. So one hypothesis was that annual birthing of juvenile bats might drive Nipah circulation. But what we saw was actually that the birthing of juveniles wasn't that connected to Nipah outbreaks in bats, but rather the waning of antibodies over time. And we saw outbreaks happen in this population on about an every 2-year cycle. So that speaks to really the point that in any given bat population, Nipah outbreaks are really tied to herd level immunity in that locality. When we looked at different viral strains that were detected both in bats and compared them to people, one of the main things we saw is that there are multiple strains of Nipah-like viruses circulating in Pteropus bats. In this study, we looked at bats across Bangladesh. We saw strains associated with the Bangladesh clade of Nipah virus, so matching what was found in humans over that 6-year period. But we also found strains of Nipah virus that were more closely related to the Malaysia clade of Nipah virus, showing that there are multiple types of virus circulating in these bats. And, as we're learning more and more in India about the strains of Nipah circulating there from colleagues at ICMR, we're learning that the same is probably true, that there are multiple strains circulating over a broad geography in these bats, but much more work has to be done to understand the true diversity of Nipah virus in these bats. The question of what role livestock might play, because livestock were such an important feature in the Malaysia outbreak where pigs were getting infected. We did do a study in Bangladesh looking at exposure to Nipah virus in nomadic pig herds, these small rural herds of pigs that are brought from village to village. And we found that about 45% of pigs we tested had non-neutralizing antibodies, IgG antibodies against Nipah or related viruses. Without a history of disease per se, but we see that pigs are getting exposed. And to a lesser extent, goats and cattle also had evidence of exposure to Nipah virus. And so we can't ignore domestic animals, particularly mammals like pigs, as a potential avenue for this virus to emerge from bats into people. And in this context, we imagine pigs might be getting exposed as they forage for food in and around bat roosts. As bats are roosting in the trees, pigs might be picking up pieces of dropped fruit with bat excreta on them. And we also know that it's common for farmers to feed dropped fruit. That's fruit with bite marks in it found on the ground. They'll feed that fruit to their livestock. And if that fruit happens to have been bitten and dropped by a bat, it may be contaminated with excreta and occasionally Nipah virus. So this may be another route of spillover and transmission. So what do we know about what really drives Nipah virus spillover? Well, wildlife provisioning is a major one, and we have to recognize that these bats are very ecologically important and live quite closely with us. And so they're going to share a lot of our food resources and environment. So we have to be aware of that and maybe look at the way we practice cultivating fruit, date palm sap, and other food resources that have the potential to be utilized by bats and could be a route of spillover or transmission, both to people and to livestock. We have to pay attention to our livestock production systems and make sure there's adequate biosecurity, which simply means separation between the animals we're raising and wildlife surrounding those farms. Deforestation may play a role in Nipah virus spillover. We see that Pteropus prefers fragmented forests. And so in areas where there are large tracts of intact forest that may be undergoing the process of fragmentation, that could be an area we should be paying attention to that might draw bats in for taking advantage of humanized environments in those areas. And we're still learning about climate change, but to date, there are studies showing that spillover events in Bangladesh may correlate with monthly rainfall and tend to happen in cooler, drier months. In Australia, there was an excellent study done there looking at Hendra spillover to horses. Hendra virus is related to Nipah virus, and spillover being linked to El Nino events and perhaps associated food shortages for bats that bring them into farming areas or more urban areas and into closer contact with horses. So here's where One Health really comes into play. This system, this notion of Nipah virus isn't unique to Nipah virus, but it's certainly a theme we see a lot, which is wildlife and people coming into greater contact because of human activities, things we are doing that change the environment around us and bring us and our domestic animals into closer contact with wildlife and create opportunities for spillover of whatever viruses might have been normally circulating in bats or rodents or non-human primates or whatever it may be. And we have to realize that it's our activities that are driving spillover. And that requires integrated surveillance. We have to be simultaneously paying attention to our domestic animals as well as human populations that might have high rates of contact with wildlife. I did want to emphasize that public-private partnerships have been really critical in helping us understand the ecology and epidemiology of viruses like Nipah. That's research groups that are working along government entities where the research activities provide information and resources that support surveillance activities undertaken by the government, and vice versa. Public health systems have really helped researchers understand Nipah virus epidemiology. And the reason I bring this up is that moving forward, this really has to be our model globally, I believe, because there is just too much work for any one sector to do it all. Anthropologic studies, the understanding locally in a local context of what motivates human behaviors that might bring them into closer contact with wildlife or create opportunity for spillover. We have to have local experts who understand cultural and local contexts, understanding what's going to motivate people to make the slight behavior changes that could reduce the risk of spillover. And then ultimately, we need to develop interventions and policies that reduce the risk of spillover. That's truly what prevention is focusing on that human-animal point of contact or interface and trying to limit opportunities for spillover. So with that, I thank you very much for your attention and look forward to hearing presentations from my colleagues. Thank you very much.
Thank you very much, Dr. Epstein, for that very, very enlightening talk and very, very well presented. You spoke about the critical importance of Nipah viruses in context of human health, their reservoirs, role of bats in transmission of Nipah viruses, how spillover is triggered, and how can we adopt various One Health strategies for prevention. Thank you for that very, very elaborate, well-presented talk, which was very explicit. So with that, I would like to invite our esteemed next speaker, Captain Joel M. Montgomery. So Captain Joel M. Montgomery is currently the Chief of Viral Special Pathogens Branch in the Division of High Consequence Pathogens and Pathology of the National Center for Emerging and Zoonotic Infectious Diseases at CDC. He oversees a diverse portfolio of public health research, response, building collaborations with countries, and also enhancing their capacity for handling high consequence pathogens such as Ebola, Nipah, Lassa, Hanta, CCHF, and there's a long list. Formerly, he was the chief of the Division of Epidemiology, Informatics, and Surveillance Laboratory branch in CDC's Division of Global Health Protection. So it's my proud privilege to invite this very, very eminent speaker, Captain Joel M. Montgomery, to deliver his talk, for which we are very excited. So a big round of applause for this very eminent speaker. And over to you, Captain Montgomery.
Thank you, Dr. Gupta. Gupta, can you hear me okay? And you can see my screen?
Yes, yes.
Okay, perfect. Again, thank you. Echo comments, opening comments from Dr. Epstein, from John, also a very close colleague. Appreciate the invitation from ICMR. It's truly an honor to meet with you all this evening and to talk a bit about what we are doing in the Viral Special Pathogens branch with respect to Nipah virus. So John's done a wonderful job of kind of setting the stage for Nipah, the background and history. I'll talk a little bit more specifically about the work we're doing in Bangladesh with colleagues at ICDDRB and IEDCR, and the work we've been doing with them really for the past 20 plus years. What I'll also touch on is some of the new work we've been focusing on here in the branch, specifically with respect to the medical countermeasures that are being developed. So before I start, a little bit of background about the branch and what we do. Nipah is one of a number of high consequence viral pathogens that we work on here in the branch. Last count, we have around 38 to 39 different high consequence viral pathogens that we work on, many of which are select agents, biosafety level 4. The focus of our branch really there's three main areas of focus. One is outbreak response, conducting epidemiological investigations, assisting countries with rapid response, mobile lab support, and capacity building. And again, I'll talk more about some of the work we've been doing with Bangladesh over the years with respect to outbreak response and surveillance. Also, ecological investigations, which I won't go into too much detail on this presentation today. Similar to John's presentation, we provide a significant amount of support during outbreak responses, particularly in ecological investigations, vector studies, reservoir investigations. And then the last piece that I will touch on more is our specific research that we do here in our laboratories in Atlanta. That is the molecular research, specifically translational research, research that leads to public health interventions, and also product development. And I'll talk again more specifically about some of the therapeutics that we are currently working on here for Nipah virus in the branch. So over the years, and I'm really just talking about from 2000 on, our branch has been involved in quite a few responses. You can see here, not all this is Nipah, obviously. A lot of work on filoviruses is what we do in the branch, Ebola, Marburg. But really, if you go back to 2000, 2001, with some of the first discoveries of Nipah that John described in Malaysia and Singapore, later in Bangladesh, the branch has really been involved and Nipah virus research and investigation and surveillance since the very beginning, since the discovery of this virus, and have been involved in some of the key investigations, particularly in Bangladesh, with respect to identification of some of the first evidence of person-to-person transmission back in 2003 and 2004. And then more recently, we've been involved in some of the larger outbreaks in Bangladesh in 2023, this year, which I will describe in more detail, because I think there are some unique findings from this investigation, from this outbreak, that allow us to better understand some of the transmission dynamics of the virus. In 2006, again, after the first discovery of Nipah virus in Bangladesh in 2001, we initiated a large cooperative agreement with the International Center for Diarrheal Disease Research, Bangladesh, or ICDDRB, in collaboration and cooperation with IEDCR as well. And with this cooperative agreement, really helped to establish surveillance for the first time in Bangladesh, a really comprehensive surveillance platform in Bangladesh. And that has been ongoing really since 2006. It started out with just a few key locations where Nipah virus was known to transmit, where we had seen outbreaks, particularly in areas like Goalando and Faridpur, just outside of Dhaka. And that has significantly expanded since 2006. The number of sites now that are under surveillance, as you can see here in the map on the right, there's quite a few. There are 10 active surveillance sites at tertiary care hospitals. We have also ICDDRB and IDCR have also incorporated 2 district hospitals, passive surveillance. And I think the most important points on this slide is there has been a significant bolstering of surveillance, particularly enhanced surveillance, with the expansion of 402 hospitals across the country. And I think that has really been an important component and an important addition in what Bangladesh is doing for Nipah virus surveillance. It's helped us to better understand some of the distribution of transmission, quicker outbreak detection, and more rapid response. And John kind of alluded to this in his presentation, and I'll talk about it a bit more later. In Bangladesh, there is a very distinct location, at least historically, known for transmission of Nipah, referred to as the Nipah belt. Although, and again, you saw in John's graphics of bat distribution, Teropus is really, the distribution is widespread across Bangladesh. But the outbreaks have really been limited to certain locations within Bangladesh. Part of this is likely due to surveillance bias. So again, what we've done is expanded the number of sites so we can better define the ecology and the epidemiology of transmission of Nipah in Bangladesh. And also this past year, they have, the government of Bangladesh has also started up a 24/7 event-based surveillance. So it's a hotline-based, cell phone-based, phone-based surveillance system to rapidly detect cases in the community. So the landscape of Nipah virus in Bangladesh, again, it was first identified in 2001, and then really surveillance was stood up in 2006 with massive expansion across the country, as I've already described. Since 2001 through the latest outbreaks this year, December, January, there have been 339 cases of Nipah documented. Likely more than that. These are just the cases that have been detected through surveillance. As John mentioned, the case fatality rates have been quite high. The case fatality rate in Bangladesh alone, they've seen up to 71% mortality rates among those cases. And likely it's, and I'll talk more about this later, but likely it's because many of these cases are presenting to the clinic very late in their infection. So those mortality rates are typically much higher. We have seen up to a 28% person-to-person transmission rate in Bangladesh. And I noticed there during John's presentation, there were a couple of comments in the chat that we can hopefully address later, questioning the concern about person-to-person transmission and the pandemic potential of this virus. But we have seen quite a bit of person-to-person transmission in Bangladesh. And I know in India, the most recent outbreak in Kerala, you also did see quite a bit of person-to-person transmission. Again, John's already talked about the reservoir species Pteropus, the source of Nipah in the environment. In Bangladesh alone, we've seen spillover from bats at least 146 times through consumption of raw date palm sap. Some of the initial outbreak investigations in Bangladesh back in the early 2000s, it was not known that date palm sap was a potential source. In fact, there was a lot of confusion early on in the outbreaks in Bangladesh as to the actual source of Nipah, given our history and understanding of transmission of Nipah in Malaysia, with the intermediate host being swine or pigs. The population of pigs in Bangladesh is just not as widespread as you see in other regions in South and Southeast Asia. So there was a lot of confusion early on as to the potential source of infection to humans. And then finally, the connection was drawn directly to bats through consumption of partially eaten fruit, again, as John mentioned earlier in his presentation. And then it wasn't really until 2004, 2005 that this connection to date palm sap was really identified. In Bangladesh, there are 89 survivors of the 339 cases that are under follow-up. So there's a lot of work now being done on survivors to better understand potential for relapse, potential for recrudescence of infection. But I think also equally important, understanding some of the long-term sequelae associated with illness. We are seeing some significant sequelae in some individuals, motor skill, loss of motor skill, and other significant problems, physical problems post-recovery. In Bangladesh, the distribution of Nipah is over 34 districts, as shown here on the right in the map, out of 64. And again, we typically see transmission of Nipah within a particular time of year, that is December to April, as John mentioned, and it's likely associated with date palm sap harvesting. As he also mentioned, the bats have learned to exploit this date palm sap collection time. So it places the virus in the bats in closer proximity to humans during this time period. So not only do we see transmission within particularly areas of Bangladesh, but we also see transmission within certain time periods. Interestingly, the most recent outbreaks in Bangladesh really didn't catch a lot of attention. And one hypothesis is because of the COVID pandemic, there was a loss of institutional memory of Nipah in Bangladesh. And so there wasn't a whole lot of attention early on. And again, I mentioned since 2001, there have been recurring outbreaks and cases of Nipah. So it's because their surveillance is so efficient and so good, they're able to rapidly respond to these outbreaks and keep these clusters small. So it doesn't gain a lot of attention. However, in this most recent outbreak in December 2022 into January of 2023, we did see, similar to Kerala, a significant amount of person-to-person transmission. So it actually did make the news again, both domestically and also internationally. So it raised the concern that, again, Nipah has the potential to become a pandemic. It is an RNA virus. It is highly mutable. And there are these clusters occasionally of person-to-person transmission. So there still is a lot of concern that this virus could become a pandemic because of its person-to-person transmission potential. So the outbreak again in 2023, end of December, beginning of January 2023, 14 Nipah virus cases were detected And they were distributed over 7 districts, including one new district. And I'll talk about this a bit more later. Case fatality rate, again, was around 71%. And 4 survivors out of this outbreak are now under follow-up. One new finding during this outbreak was, well, actually 2. One was detection of Nipah virus for the first time in breast milk. And there was also strong evidence of mother-to-baby transmission. What we can't tease out in this event was if the transmission occurred in utero or post-delivery. But there was definitely virus found in the breast milk. So certainly a potential for that as a source in future outbreaks. What they did during this outbreak was, again, a lot of, as I mentioned earlier, a lot of loss of institutional memory of this virus in the communities. So they rapidly scaled up communication materials, both in English and Bangla, and distributed these across the country, but with a big focus in schools, which did provide a lot of educational materials to the children that then took this information home to their families. So they were able to disseminate the information quickly and get Nipah back into the front of everyone's minds. Again, a lot of this history of Nipah had been lost, or understanding of Nipah, likely due to the COVID pandemic. Again, I mentioned that there is this, what is referred to as the Nipah belt in Bangladesh. And again, it's likely due to some surveillance bias. Again, the bats are all over the country. But what we saw in this outbreak was actually kind of a unique finding, and actually a very concerning finding. Again, date palm sap has been linked with transmission in Bangladesh. Typically, the date palm sap is collected locally and distributed locally. But beginning in 2023, end of 22, beginning of 2023, there was kind of an entrepreneurial enterprise that was started up that was actually distributing date palm sap across the country. So now you can get date palm sap across the country, really now any time of the year. So what a lot of groups are doing now is they have social media posts promoting sale of raw date palm sap. So they're collecting the date palm sap, in fact, in some cases out of season, and storing this frozen and shipping it, so you can get on your cell phone, download an app, and find out where date palm sap is being sold. So we actually identified a case in Narsingdi province that is an area that's not known for Nipah transmission. In fact, the case that was infected in that location, the only date palm sap that they had consumed was date palm sap acquired through this social media post and the date palm sap app on their cell phone. So quite concerning that the distribution of date palm sap now across the country could increase exposure. There is also some suggestion that the date palm sap is being sent outside of Bangladesh, but I think more to go, more to learn on that. Also forgot to mention that the date palm sap too that they sell through these apps, it's raw date palm sap, so it's not pasteurized, it's not sterilized in any way, so it potentially has infectious virus in it. So for prevention and control strategies, really awareness is key to preventing transmission. Again, educating people to avoid drinking raw date palm sap, to not handle live or dead infected animals, to not eat partially eaten fruit that's been partially eaten by bats. Again, surveillance is also key to success to prevent transmission, identifying cases quickly to prevent additional transmission from person to person. But really, the big focus, again, and I'll end my talk with some of the work we're doing here on some of the vaccine development. Really key is treatment once cases have been identified. And as John mentioned, there currently are no FDA or WHO approved vaccines or therapeutics for Nipah virus. So again, kind of the work we're doing right now, as I mentioned already, we do applied research here in our branch, translational research. So we do animal model development, therapeutic screening, high throughput screening, and product development, that is vaccines, antiviral drugs, and diagnostics. I'm just going to show a couple of things that we're doing here in the branch, that is advanced molecular techniques to allow generation of reporter viruses. So we now have Nipah virus that has fluorescent proteins that are incorporated into the virus, so we can visualize growth and also visualize inhibition of growth. So what you're seeing in the left-hand panel here is a Nipah virus, a recombinant Nipah virus that we have inserted a green fluorescent protein so we can visualize growth. But more importantly, we can actually measure reduction in growth through reduction of growth when we're screening for certain antiviral compounds. And on the right, you can see our again, the same green fluorescent protein expressed virus. We can visualize the virus growing in different animal models that we've developed. So here in the A panel, you can see that Nipah virus is in the heart and lungs during the acute respiratory phase, and then over time it moves into the brain. So again, it helps us better understand the pathophysiology of the virus with some of these recombinant viruses. One product that we are focused on now it's a virus replicon particle vaccine. It is actually mucosally delivered, so it's delivered intranasally. It is a vaccine candidate that we've been developing and working on and evaluating. And you can see here in the middle panel under survival, this VRP induces a rapid production. It's 100% efficacious with no clinical signs only after 7 days post-vaccination. So we get 100% protection. But more importantly, we have high level of protection only 3 days post-vaccination. So this vaccine, again, we've only gone into preclinical trials in hamsters, but this could actually theoretically be used for outbreak control because of its rapid protection 3 days post-vaccination. It also shows a significant reduction in viral shedding. So again, it could be used much like the VSV Ebola vaccine. It could be used during outbreak settings or to vaccinate other high-risk individuals like healthcare workers. In addition to the vaccine work, we're doing a lot of antiviral work. So screening assays to identify potential Nipah virus antiviral compounds. So the efficacy testing of promising anti-Nipah compounds at CDC is also in collaboration with other institutes. So we've screened a number of different small molecule drugs like remdesivir, and they have shown some strong promise at reducing severity of illness in non-human primates. As John mentioned earlier, and I did as well, there are no FDA or WHO approved drugs or therapeutics like monoclonal antibodies. However, ribavirin has gone through some off-label use. It's widely available, so there could be some promise with ribavirin. Monoclonal 102.4 has gone through phase 1 trials and has shown some really good efficacy in non-human primates. Favipiravir has also gone through some preclinical screening. I think the important point of favipiravir is that it can be administered orally, which is important. And then, of course, remdesivir has gone through also some preclinical phases. So I've listed 4 here in the table, but there are actually 8 different drugs that have been tested in vivo and 7 in vitro. And then as far as vaccine development, I mentioned already ours, the VRP vaccine is showing some promise preclinically, but there are also at least 4 or 5 additional vaccines that are in phase 1 trials and some in preclinical. And then the last one near the bottom, the Chadox vaccine, that actually will likely go into phase 1 clinical trial in Bangladesh in the next few months. So I'll stop there and back to you. Thanks.
Thank you very much, Captain Montgomery, for that very impressive talk of yours, where you spoke about the effective surveillance that have been set up in Bangladesh, where you are capturing regularly the trends of Nipah virus disease. But most importantly, what you spoke about, and I think the public knowledge about these aspects is not very good, that you spoke about the sequelae of Nipah virus disease. I think that there's very little data on that. And also you raised a concern that Nipah virus can become a pandemic due to its potential for person-to-person transmission. And we should raise our guards and keep on doing effective surveillance to see the trends of this disease. And the other important aspect that you referred to was the possibility of transplacental transmission and secretion of the virus in other body fluids like breast milk. And also the other concerning part that you raised was that Nipah virus is slowly spreading out of the so-called Nipah belt. And also you showed us the research portfolio of CDC as well as the medical countermeasures that are under development for Nipah virus disease. So thank you very much for this very illuminating talk. And I would now move on to the next speaker that we have, Dr. Kadambari Deshpande. Dr. Kadambari is an ecologist, and very recently I got an opportunity to see her very impressive work in one of the ICMR meetings. She has been conducting interdisciplinary studies on human-bat interactions in diverse habitats, from forest plantation mosaics to peri-urban landscapes, in different socio-cultural settings for over a decade. Her research interests are in the ecology and behavior of frugivorous and insectivorous bats, impacts of anthropogenic change on bat communities at local and landscape scales, and local people's knowledge and perceptions of bat-generated ecosystem services to inform strategies for bat conservation and human well-being. So a very warm welcome, Dr. Deshpande, and we look forward to your talk. And you have 10 minutes to make your presentation. Over to you, Dr. Kadambari.
Dr. Kadambari, I think you can unmute yourself.
Sorry.
Yeah.
Am I audible now?
Yes, please, go on.
Yeah, so sorry about that. Thank you very much, Dr. Gupta, for the kind introduction. And I thank ICMR for giving me this opportunity to present my work in front of all the eminent scientists here. So just to begin, this year, a fourth outbreak of the Nipah virus occurred in Kerala's India's Western Ghats. And questions again arose on the pathways of Nipah virus transmission in Kerala. So as we all know, fruit bats are known reservoirs, and therefore understanding their ecology, especially in human-dominated landscapes, becomes crucial in this regard. So bats can be broadly classified as frugivorous and insectivorous. They are highly beneficial to forests, agroecosystems, as well as urban ecosystems. For instance, fruit bats are very important seed dispersers as well as pollinators of many forest trees, agricultural crops. Insectivorous bats are important insect pest controllers, and also their droppings can be used as effective fertilizer in agriculture. At the same time, there are also costs from bats to people. For instance, fruit bats are perceived as pests of fruit orchards, and they're also disliked due to biofouling of built-up places. So as we can see, bats can have simultaneous positive and negative impacts on people. So fruit bats and humans have been sharing spaces for centuries in diverse habitats, as I just mentioned, in forested areas, agroecosystems, peri-urban areas, as well as metro cities. The health of fruit bats and the health of neighboring people are also connected, as an aberration in one can actually affect the other in some way. And this is the One Health perspective, defined by the WHO as an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. So I have been working on bats in the Western Ghats for over a decade, and my work started in Kerala. During my interactions with plantation-associated people in that region, I came across very interesting narratives of their interactions and experiences with fruit bats in particular. I realized that fruit bat human interactions were not only more common, but they were also more positive than one would think. So in many landscapes, including Kerala, people had keen observations of fruit bat behavior and actively tracked seed dispersal by bats. Seeds dropped and aggregated by bats under feeding trees or roosting sites would be particularly collected, sold, and also auctioned for high value in some regions. Bats pick the ripest fruit and after chewing the external part, drop the undamaged seeds or nuts in clumps. People reported that tracking and collection from these aggregations reduced their dependency on labor, as labor availability in these plantations is becoming dearer by the year. Seed dispersal, especially of cashew nuts and areca nuts by bats, was really beneficial for people across the Western Ghats, especially in Kerala. At the same time, bat frugivory on cashew apples, areca fruits, and also other pulpy fruits caused some fruit damage and losses. However, in my work, I discovered that overall benefits from bats were perceived by people to be far greater than the costs. And this was quite a novel finding given the general distant impression of bats being mere pests. So from my studies, I estimated that above 50% of cashew nut collection included bat-bitten and dropped fruits. And this was also because farmers preferred bat-bitten fruits as they were easily found below the feeding trees at the right time when the seeds were ready. But then what about risks from bats? We know that both fruit-eating and insect-eating bats are reservoirs of several pathogens. Many of them can be life-threatening as well. And this includes Nipah, one of the latest threats at our doorstep. It may be worth noting that such tracking of bat drop seeds involves significant handling of fruits as well. Not only that, there are other undesirable interactions too. Handling of dead, electrocuted, or injured bats is a regular practice in plantations. Additionally, bat hunting across the Western Ghats and in many regions in India is quite common. This is mainly for bat meat, certain unproven medicinal purposes, or as part of rituals. All these acts can actually be potential risks. So these observations made me wonder whether fruit handling by seed collectors who are collecting these bat-bitten fruits, bat-dispersed seeds so enthusiastically for benefits could be a potential risk factor. Imagine an early morning in a fruit plantation, say of cashew in the Western Ghats. You can see plantation workers collecting fallen cashew apples early in the morning, especially during summer, peak summer. A plantation owner or manager walking in their fruit plantation can casually pick fallen fruits with bare hands. Anyone who has walked these plantations would have noticed this. But experimental studies have shown that Nipah virus can stay on fruit surfaces for significant amounts of time, for about 2 hours to more than 30 hours, depending on ambient conditions. So in this morning seed collection context, people could potentially be exposing themselves to bat-eaten fruits dropped in the previous night or just a few hours back. So why are we focusing on cashew and areca in particular? These plantations are common across the Western Ghats, and I found that bats also commonly feed on them. In the case of cashew, it has a pulpy aromatic fruit, which bats like a lot. And the peak fruiting season of cashew is in peak summer. That time, the cashew apples are generally left on trees to ripen naturally, while other fruits are harvested unripe. So they are available for bats to feed on. In the case of areca, it is a fibrous fruit. Although it's a fibrous fruit, it is available in the post-monsoon period when there is general food scarcity. So as we can see, The utilization of cashew and areca plantations by bats is different from other fruiting trees in their respective season, which is an attribute that potentially makes human-bat contact more common and risky, probably, in these plantations. All this also while yielding high economic benefits to people from clump seed dispersal by bats at the same time. So we published this paper in the journal EcoHealth, and you can read the insights in detail in this publication. So despite all this, despite the high prevalence of such seed collection activities and bat visitations, spillovers are still relatively rare. For a pathogen spillover to occur, many factors at the local scale as well as the landscape scale need to act together, both spatially and temporally. So what could be the multiple converging factors? As I just described, apart from routine human-bat contact pathways, other factors can actually contribute to physiological stress in bats. Deforestation, fragmentation by non-food commercial crops, and also climatic extremes like heat waves, El Nino droughts can aggravate stress and viral shedding in bats. Fruit bats can... I'm sorry, there was a... Hello?
Yes, Dr. Kanami.
There is some request that I'm receiving. I'm very sorry about this.
That's okay. Can I hear you?
Yeah, there are lots of requests to have remote control of my screen. I don't understand that.
It's okay.
Anyway, yeah. Fruit bats can also have highly localized foraging or also long distance movements, depending on food resource availability mainly. In Australia, as Dr. Epstein also just mentioned, from 25 years of data, it was shown that land use change and El Nino events led to persistent bat roosting in agricultural areas in particular, and periodic food shortages drove spillovers. This indicates that all these factors could lead to increased visitations of stressed bats to fruit plantations, such as of cashew, in peak summer, which is also their breeding season, which could potentially add stress in bats. So it may well be possible that fruit bats may be acting as potential arenas of human-bat contact, as well as viral spillover. So overall, for zoonotic spillover, a lot of factors have to act together. The probability of bats being infected by Nipah virus, the same bats being under physiological stress and shedding the virus, and then spilling of virus through a bridging host or livestock or directly through human contact with bat-bitten fruits. From here, human-to-human transmission can lead to a wider spread. So, to think of awareness, awareness in Kerala has been great because of high preparedness and Kerala being one of the highly responsive states. This has led to many people avoiding eating bat-bitten fruits. But safety measures in daily plantation activities remain absolutely important. There is an urgent need to increase the capacity and awareness of local people, especially those associated with food plantations, in rightly recognizing the risks while continuing their practices adaptively and in safer ways. Regular health monitoring of bats at roosts for seasonal turnover and migration, reproductive phenology, mortality, disease, etc. must be systematically done. And overall, tracking the chain of different causal probabilities with studies on bat behavior, human behavior, and human-bat contact pathways in different socio-ecological contexts will be quite critical. There is a need for objective assessments of bat-linked ecosystem services and risks for effective conservation and public health action. It cannot be forgotten that bats are highly beneficial to plantation economies and forest ecosystem health despite potential risks. People's positive perceptions, attitudes, their adaptability make me optimistic about achieving safe coexistence between healthy bats and healthy people in healthy ecosystems. And this can possibly be done through realization of the One Health approach on the ground by integrating the different methods that we discuss here. Thank you.
Thank you, Dr. Kadambari. And I must compliment you for working in a very difficult ecosystem and present to us very objective evidence on what could be the possible risk factors for Nipah virus disease along the Western Ghats in India. And I must tell you that we at ICMR have been working on Nipah virus disease, but the information that you present is very, very unique and very enlightening for us, and also gives us an opportunity to explore newer arenas, of course, in collaboration with people like you. So thank you very much for your excellent talk. And with that, I would like to invite the next speaker whom we have with us, Dr. Anoop Kumar. I must say that Dr. Anoop Kumar is a very astute clinician. He's the Director of Critical Care Medicine at Aster Hospital in Kerala. And he has been seeing a lot of Nipah patients. In fact, in every outbreak, he is the person who is able to detect, responsible for early detection and also containment of outbreaks and appropriate management of the infected patients. He's received many, many awards from the government of Kerala for his excellent work towards detection, management of Nipah patients, and also handling them with very, very appropriate precautions. So, Dr. Anoop, we are really privileged to have you today and present your experience, the Indian experience on managing the Nipah virus patients. So over to you, Dr. Anoop, and you have 10 minutes to make your presentation. Thank you.
Thank you for that kind introduction, and thank you so much for giving me this opportunity. Hope my slides are visible.
Yes, sir. Please.
Yes.
Okay. So as you are well aware, in India, we had almost 6 outbreaks starting from 2001 and 2007 in West Bengal, and in Kerala 2018, 19, 21 and 23. I was personally involved in 2018 and 23 outbreak, and again my colleagues were involved in 19 and 21 outbreak. So the clinical features will be basically my experience sharing and the information what I gathered from my friends who treated this outbreak. So we'll start with the first outbreak, how we detected. That was in 2018. So I'm basically a critical care physician working in the north part of Kerala. So in 2018 May, we have received a patient in our emergency department, a 26-year-old man without any previous comorbidities. So he presented with 3 days of symptoms. So he basically was having a fever, vomiting, a severe breathing difficulty, and he was not having any cough. And on arrival to the emergency department, he was restless and he had an altered sensorium. So a patient coming with fever, altered sensorium, we think about the possibility of acute encephalitis or acute encephalitis syndrome, and he was shifted to the medical ICU. So before shifting to the ICU and before proceeding with the CSF analysis, we have done the CT head for this patient, which was showing significant brain edema. So we didn't proceed with immediate intubation. So we didn't proceed with the immediate CSF analysis. We decided to electively intubate him in view of the worsening sensorium and hypoxia. And after that, we have started him on anti-edema measures. So during the examination, the findings we observed were he had severe tachycardia and hypertension. Usually any patient, once we sedate and intubate, they go for like hypotension, and usually they will not show much hypertensive response. But this patient was showing a severe hypertensive response or an adrenergic response. Then he was not having any other abnormal neurological signs at that point, and other respiratory system and cardiovascular system examination was also normal. So while investigating this patient in detail, like we were taking the history, so at that point we came to know that his brother has died in a nearby government medical college almost 2 weeks back with almost similar symptoms. He also presented to the hospital with features of ARDS and encephalitis. He was selectively intubated, but he developed multi-organ failure and died within few hours. That's why they couldn't proceed with much investigation at that point of time. So as we had a primary case 2 weeks before, and a person from the same family developing similar symptoms, we encouraged the family members, is there any other persons in the family having similar symptoms? So they initially denied that, but on repeated questioning, they agreed that 3 family members, like this patient's father, aunt, and fiancé, they are having symptoms, fever, but they were not having any significant respiratory symptoms, and they are taking treatment from the local general practitioner, and they are doing fine at home. But we have insisted this family to bring these patients also to the hospital, and subsequently they also got admitted into the hospital. So right now, so we have having like 3 patients, and 1 patient died before. So these patients, when we were observing, so they were having adrenergic response, like severe hypertension, tachycardia. The patients admitted with fever initially, they also developed features of encephalitis within few hours. And those patients were having a segmental myoclonus. 1 patient was having ptosis and pupillary asymmetry, and the segmental sweating was also observed. So now we have a cluster of patients with these abnormal symptoms. And when we analyzed these abnormal symptoms in these encephalitis group of patients, in the previous NEGM paper about Nipah, that is the Malaysian outbreak, all these features of abnormal pupil, then again adrenergic response, segmental myoclonus, cerebellar signs, ptosis, all those were described. So with these clinical features like tachycardia, ptosis, segmental sweating, hypertensive response, abnormal pupil, then segmental myoclonus, seizures, then the dysarthria, cerebellar signs, etc. We we were thinking about the possibility of Nipah or some other new evolving viruses. So here in this, so after that, the initial patient, we have proceeded with an MRI. So it was reported normal at that point, and the brain edema was subsiding. So we decided to go ahead with the CSF analysis. And the CSF analysis in all these 3 patients were almost normal. You can see the cell count were normal. In 1 patient, there was a slight increase in the CSF protein. Other than that, the CSF were normal. But as you all are aware, even in any viral encephalitis, you can get a normal CSF picture in the initial days. And the previous, the data in Nipah also shown that you can have a normal CSF picture with normal cell count. So that again, made us a clue that it can be an abnormal viral illness. So putting these points together, like we had an index patient 2 weeks before, then there are clustering of symptoms, and there are unusual clinical features which I have described. So these made us our clinical team to think about the possibility of an unusual viral syndrome, because we are like coming across so many viral encephalitis in our area, but these features were not observed. So we decided to evaluate for this unusual viral syndrome, and the samples were sent to Manipal Virology Institute at that point of time for the encephalitis workup and for the Nipah PCR as well. So we have sent urine, blood, throat, and CSF. And subsequently, we had 2 more patients in our hospital. And you can see like the CSF was negative for all these patients. So as a part of routine encephalitis evaluation, if we would have proceeded with only CSF analysis, we would have missed those cases. And you can see like consistently there is a positivity in urine, and throat swab also there is a positivity. So after that, in that outbreak, we have decided to go ahead with throat swab and urine analysis for all patients, and not with CSF for all patients. And the CBC pattern was also showing in few patients had a slight hemoconcentration, like in dengue, and mild thrombocytopenia, and a microscopic hematuria in few patients, and albuminuria also. And this MRI, when we reviewed again, you can see this T2 hyperintensities here, small, minute hyperintensities. And this is typical of these Nipah encephalitis. Even though you can see it can be seen in other encephalitis also, we have observed these findings in these cases. And again, the previous reports also, you can see these T2 hyperintensities, and in the diffusion images, you can see this the bright spots in the brain imaging. So that time we had almost 1 patient initially. He was spreading when he was admitted in a local hospital to another 10 cases. Then when he was shifted to another medical college, the initial patient, he again transmitted to another 10 patients, and almost then in the second series, there were 3 patients. So altogether, we had 23 cases at that time, and officially only 19 were reported, but because we were able to test the PCR only for 19. And we were able to pick up the cases from the second series of patients, and other cases were subsequently picked up from the contact list also. And in that series, we had almost 37 patients, percentage of patients with encephalitis ARDS, and the myocarditis were also observed. And one issue in that series were, like, initially we thought these patients are having myocarditis, but we did an autopsy for one patient, and the histopathology from the autopsy specimen did not show any features of myocarditis. So that made us to think whether it is a stress cardiomyopathy or not, because these patients were having severe adrenergic surge initially. And almost all patients were having primary neurological syndrome, and few patients were having the neurological plus respiratory symptoms, and one patient was having only ARDS. So then afterwards, in 2019, in Cochin, we in one of our other hospital, Aster Cochin, there was a boy who presented with the fever-altered sensorium of 12 days duration. And his routine investigations, the clinical features, everything were normal, but neurological examination showed nystagmus, dysarthria, and he had the features of cerebellar signs like gait ataxia, etc. And the routine investigations were almost normal, but his imaging again showed multiple T2 hyperintensities, and initially they thought it may be something like a septic emboli, and they have evaluated for infective endocarditis even with transthoracic echo. And subsequently, it was sent for a multiplex PCR, and that PCR showed a Nipah positivity. So it was detected from that multiplex PCR in the CSF. And the CSF analysis in that patient was showing a slight lymphocytic predominant picture. And then in the third outbreak that has happened in the same hospital where I'm working now, in Aster, means Calicut, that was a 12-year-old child admitted with fever, seizures, and myoclonus. So that child was also having focal seizures, MRI findings, autonomic dysfunction, and the CSF abnormality as well. And here again, you can see this in this child also, multiple T2 hyperintensities. And this patient was ventilated, given all the care for an encephalitic child, but we couldn't rescue that child. In 2023 now, what has happened is, like, we have received a cluster of patients of 4 from the same family with again fever, dry cough, etc. And in that history taking, we came to know that the one of the family members died in another hospital with severe ARDS and multi-organ failure almost 2 weeks before, without any proper diagnosis. They have done a respiratory panel, but all the routine viruses were negative. At this, we made a medical team to evaluate that. And while evaluating that, we received another patient who died immediately after reaching the ICU. He had also a severe viral ARDS-like picture. So we were then subsequently, these 2 patients were tested positive, and from the dead body also, the samples from the dead body also later tested positive for Nipah. So here we had an index patient, then clustering of cases, then unusual clinical symptoms like slurring of speech, diplopia, seizures in this the one initial patient, and the subsequent one child who was admitted. So and along with that, these patients were from the previous Nipah epicenter. So these also made us to think about the possibility of Nipah, and we were able to send the sample immediately, and subsequently it came positive. And this time also we observed a minimal hemo concentration and slight thrombocytopenia. The first patient we lost, so he had severe, comparatively a low platelet count and a significant hemo concentration. So this was observed in 2018 series also. And in this child who was ventilated, The child was on ventilator for almost 7 days. And subsequently, we could extubate this child. This child was treated with ribavirin. So here you can see the changes in brainstem and the T2 hyperintensities as well. So this time also, like initial patient, we couldn't diagnose. From the subsequent, the patient, the spread has occurred from the hospital, and the 2 family members and 1 spread from the hospital. So from those group, we were able to pick up the cases clinically. And by that time, we lost 1 more patient, and the subsequent 2 cases were picked up from the contact list. So this time, the majority of the patients were having respiratory symptoms, and few patients were having respiratory with neuro symptoms. So, like I'm not going into all these details, like these viruses can affect lung, the CNS, the kidney, heart, liver, spleen, etc., all other organs, and it can develop, the patients can develop multi-organ dysfunction. So coming to the Kerala outbreak history, the 2018 we picked up based on the clustering and unusual clinical features. In 2018, from the first case itself, the clinicians picked up based on cerebellar signs, and it was picked up from a multiplex PCR. And in 2021, it was again the clinically picked up based on MRI finding, the CSF analysis, and again the clinical features. And this time, which I've already told, along with the unusual symptoms, clustering, and from as these patients are from previous epicenter, we were able to pick up the cases. So clinically, whenever there are clustering in case of encephalitis, and when there is an adrenergic response, myocarditis, etc., along with the brainstem signs, cerebellar signs, myoclonus, along with an MRI picture, we have to always think about the possibility of Nipah, and it has to be evaluated. And the incubation period in our area was also between around 8 to 12 days. Mean incubation period were around 10 days. And exact mode of transmission from the bats to human, this is still unclear in Kerala. We are still under evaluation. And regarding the treatment, the previous speaker has already mentioned about the treatment. I'm not going into the details about that. Like as he has already mentioned, there are many other drugs tried. But here in the treatment, we have used remdesivir this time. We have used a double dose remdesivir, 200 milligram initially and 100 milligram twice daily. And when we are putting the patient on such a high dose, we have to monitor liver function test, renal parameters, and we have to look at the features of cardiac toxicity as well. Then the favipiravir is also there in our protocol, and ribavirin was used in 2018 outbreak, and this ribavirin is also used in the child whom we could rescue this time. So regarding the infection prevention, like there is like droplet infection, you have to use negative pressure isolation, PPE, then mask and contact isolation, and hand hygiene for all flu-like symptoms, ARDS and encephalitis in these Nipah-prone area, I think can prevent further transmission from the Nipah cases if you are getting further outbreak. So the immediate isolation on clinical suspicion, appropriate personal protection in all suspected encephalitis and ARDS cases, then a proper history taking and eliciting the clinical features. Those are the important things in clinically catching up the cases. And we have to always do the throat swab, urine, along.
So, Dr. Anoop, are you there? We seem to have lost Dr. Anoop on the last slide.
So anyways, I think he had already concluded his presentation. So we would like to thank Dr. Anoop. I really don't know whether he's able to listen to us right now or not, but it was an excellent presentation. And he took us through his journey of handling the Nipah virus patients, and also gave us very important clinical cues on when to suspect Nipah virus disease, and also the MRI findings that never need to be ignored. So thank you very much, Dr. Anoop, for sharing your very unique experiences and very unique knowledge with us. now I would like to move to the next speaker, who's Dr. Pragya Yadav. And I'm sure most of the people must be knowing her because she has done exemplary work in the area of high-risk pathogens and has been pivotal in the diagnosis of various high-risk pathogens in India, like Nipah and Zika when it was a PHEIC. And also, like her laboratory works on preparedness of other high-risk pathogens as and when emergency arises in India, including Ebola, yellow fever, and many more. And Dr. Pragya has done exemplary work during the COVID-19 pandemic, which involves virus isolation, development of indigenous vaccines, and also doing non-human primate studies for assessing various medical countermeasures that were developed during the COVID-19 pandemic. So with this, I welcome Dr. Pragya Yadav, and we are very excited to hear her talk. Over to you, Dr. Pragya.
Thank you, Dr. Nivedita and Dr. Anoop for invitation. And all the speakers have given our One Health approach for this Nipah disease. And I think it's a very good beginning for having this webinar series from ICMR. So if we talk about the Nipah virus diagnostic, the routine diagnostic we do for all the diseases, but what is so special about Nipah virus? So as it was described by John and also by Joel, that is a high-risk pathogen. And when we talk about any high-risk pathogen, it brings complexity of the biocontainment. And also during any outbreak, the contact tracing, and also other factor, which is not in the case of any BSL-2 or other pathogens. So if we talk about this pathogen, which is a single-strand negative sense RNA genome, has 6 structural and 3 accessory proteins. And there are other members also, which is very close to Nipah virus, and one of them is Hindra virus, which is present in Australia. As Dr. Anoop described, that in India we have total 6 outbreaks, and out of these 6 outbreaks, the number and the percent of fatality and mortality has been varied. The first one, and there will be further presentation from Manikam, where he's going to detail the epidemiology in India. But quickly, I describe that the first 2 outbreaks which happened in Siliguri, West Bengal, and also Nadia, West Bengal, the strain which circulate there is different than the strain which is circulating in Kerala. The 4 outbreak which we have seen during 2018 to 23. In the beginning, in 2001 and 2007, there was a lot of questions about how the transmission is happening, humans, and how human-to-human transmission is happening. And these questions need to be resolved with the time. And I will share some of the data which we have experienced and work on it. So during the first outbreak of 2001, India didn't have any containment facility. There was no diagnostic assay, and we could identify this outbreak in 2005 with the help of CDC. The second outbreak when happened in 2007 with 100% mortality, 5 cases. It was identified and a genome was sequenced. But again, we could not understand the source of infection. The lack of containment facility also hindered the work on other factors. Recently, when we were focusing mostly on the West Bengal, for our surprise, the outbreak happened in Kerala in 2018. And then now we see the 4 episodes of these cases. But there was another challenge when as described, that in 2001, it was mostly hospital-acquired infection, which caused 45 deaths out of 68 in Siliguri, West Bengal. In Kozhikode, similar kind of situation happened where there was a transmission from human to human, and there was a lot of panic, fear. There was no point of care assay was available, no defined guidelines on management. There was no treatment, and also there was a lack of sensitization of healthcare workers. I must appreciate the way the system took these challenges to make the protocols and further developing the capacity in Kerala in this aspect. But there another angle which we see during 2019 to 23 outbreak that we also see in the COVID pandemic. And during the COVID pandemic, when Kerala has the maximum number of the COVID cases, during that time we saw the Nipah outbreak. So managing a Nipah outbreak in a pandemic itself brings a lot of challenges. the contact tracing, the isolation of the people, finding out the right high risk and low risk population become very challenging. To resolve this, there was some very important action which was taken by Government of India. That was the first to have the BSL-3 facility in 2005. Then DHR came up with the plan of BRDL facility, which is now across the country, and COVID pandemic has enhanced number more. And then 2012, we could have the BSL-4 facility. And then recently we came up with this mobile BSL-3 unit, which is equipped with all infrastructure to deploy in an outbreak setting, and also can we handle the sample testing. All these facilities together enhance the capacity for working on any high-risk pathogen in India. In 2018, after the Kerala outbreak, WHO published this target product profile for Nipah virus, which is supposed to work on a diagnosis assay, but so far, because of the pandemic and other priorities, still is not finalized and is still in draft mode. If we talk about what kind of diagnosis required for Nipah virus, so for any high-risk group of pathogen, you want to know who are the active cases where they are having the live virus present in their body, because they will be the one who are going to transmit the disease in such setting, and they should be screened the first on priority. It means the molecular test become choice of the testing. But if we talk about the handling those infected samples, we require to have a containment facility. And from the beginning, there is always a laboratory on the site, and there is a referral center to confirm the findings. But if you're going for a virus isolation, neutralization, and other method where the culturing of the virus engage, definitely you need a maximum containment facility or BSL-3 facility. So if we talk about the Nipah, there is a lot of missing factor here, that we don't have any commercial test assay available, and we do not know how to go ahead. And this is being discussed and tried to resolve at different level. But if we talk about, if I summarize what we have today, so there are two real-time PCR which is working wonderfully, that Gulemer protocol, which was published in 2004, and then Ketan Patel from CDC, and we have tested both the protocol parallel, and they work wonderfully for the testing. But during 2018 and 19, we realized that we require a point of care test, and it was developed with the collaboration of Mall Bio, and it worked wonderfully, and it was validated with the help of Bangladesh using their serum samples and also the Indian patient samples. So if we talk about this true Nipah point of care, this can detect not only human but also bat specimen, can utilize in field setting because it work on battery, and the test results can be obtained very fast. It can utilize in any rural setting, hospital setting, and can be handled very easily. The same system was used for the tuberculosis and also for the COVID to enhance the testing in India and other countries too. In 2018, as Dr. Anoop was describing different outbreaks, so we could isolate the virus from one of the Nipah affected case, and that given more opportunity for us to be working on enhancing the diagnostic assay. We could develop indigenous ELISA, which can detect IgG and IgM for human and also from bats and pig samples. Further, the point of care assay was used in deploying many times during these years to test and see that if it is working fine. So if we summarize what other methods are commercially available, so there are certain kits available which include, but most of these kits lack sensitivity data and also the validation data. From NIV, in the beginning, we use CDC support for the reagents and also for the ELISA. But now we have indigenous kits available which can detect not only the human but also the bat and swine, the molecular serology. These are some of the other assay which we developed, and it was tested and parallelly compared to see the sensitivity and specificity. These IgG positive samples were also further confirmed by PRNT assay for the Nipah virus. So when the first outbreak happened in West Bengal, so the question was how the virus is transmitting. So we started a project with CDC where we started survey in West Bengal in northeast area, and we initially started with the 4 bat species that include Pteropus raucetus, Megaderma, and Cyanopteris species, and we could see that the Pteropus bats were found positive, but rest of the bat species not found. Further, we continue this study from 2015 to 17 in Northeast area. And after 3 years of study, we could conclude that not only West Bengal, but Assam also showed positivity in bats, not only for the viral RNA, but also for the IgG antibody. Further, we tested a large number of peak serum samples from Mizoram state using the FMD network, and we could see that there was no positivity in bats were seen. During different outbreaks from Kerala, whenever we tested the other samples, including swine samples, they are always found negative. So based on these varied presentation of the clinical symptoms, we have now a revised case definitions, which include not only acute encephalitis syndrome, but also respiratory involvements, myocarditis, and also if there is a clustering of cases in neighborhood, there is one or more additional clinical criteria, which not only suspect of AS, but also if the MRI is also presenting with the lesions in brain or spinal cord. So these are some of the understanding which we made after all these clinical presentation. The probable case is also those who are suspected patient reside in the same village community where suspect or confirmed case of Nipah living during the outbreak, or it involves suspected case patient who came in direct contact with confirmed case patient in a hospital during the outbreak. And after that, if we can confirm by a laboratory testing that include PCR from respiratory secretion, urine, or any cerebrospinal fluid, or by isolation, then it can be considered as a confirmed case. But whenever we talk about the Nipah, because of high risk nature, high mortality, and human-to-human transmission, the biosafety and biorisk mitigation become very important, not only the laboratory setting, but also in the hospital setting. So training of the doctors, the personal protective equipments, and these drills has to be done whenever the samples are handled. All safety precaution which was recommended for Ebola apply to the Nipah as well, including the sample area testing, decontamination, and that should include the waste disposal as well. So these kind of PP, which you all know has been used during the Ebola, during the COVID pandemic, should be used whenever we are taking any sample. The donning, doffing PP practices should be as per the WHO Ebola protocol, and no PP to be reused except safety goggle or face shield, which we can decontaminate. So after 2018 outbreak, there was a lot of efforts made in Kerala and there was a large number of the people who were trained using the TOT, and more than 30,000 health workers were trained during 2019. And constantly during every outbreak, there is a re-drill, there is a retraining, and there is an annual webinar on Nipah, what to do, not to do, done by state government of Kerala. ICMR trained a number of the staff, who are the VRDLs in Kerala, include Kozhikode, Alpuja, and many other VRDLs in that area. In 2019, where we have only one case who survived and there was no further transmission, actually set a perfect example that how fast we can respond to save the life, to avoid the economic losses, and also the transmission of disease. And this was recorded in the form of publication, that how we can respond fast. So now the questions come, what clinical sample to be collected? So we tested large number of sample in each outbreak, and after compiling all the results, we conclude that oropharyngeal swab, nasopharyngeal swabs, and urine are the best sample for Nipah diagnosis. But serum and serum samples are good for IgG, IgM testing. But in the case of Nipah, to connect the story, the antibody testing is necessary, but for the contact tracing and establishing the connections, the viral RNA presence is required. From 2018 to 2023, when we analyzed the data of different patients, we found that average presentation of viremia is in serum, urine, throat swab is from 8 to 9. But some of the cases also present viremia in urine and throat swab up to 17 post-state of infections. If we talk about the other body fluid, for example, semen, the virus can be present up to 26 days of post-op infections. Now the questions come, do the cases present asymptomatically or not? So at the earlier study in Bangladesh, there is no such cases were present, but in 2018 outbreaks, when the sero survey was done, with the NIE and NIV team. Among the 279 close contacts, there were 3 asymptomatic cases were found, and they were followed for a long time. In 2019, there was no such asymptomatic cases were found, and this is also presented. So if we talk about the presentation of IgM, in most of the cases, IgM is present up to 60 days, but IgG can be present in those cases where symptomatic infections are there for a very long time, even up to the 5 years. Those cases which where asymptomatic infections were seen, they are not having a long-term presentation of IgG antibody. Now come to the point of differential diagnosis. So during the 2018, when the outbreak happened, not only the Kerala, but other states also have a lot of panic. And there was a lot of referral presentation of AES, presentation of respiratory infection. And we could record the JE, rhinovirus, parainfluenza virus, adenovirus, and other viral positivity. But at the same time, during this outbreak in 2023, we could see influenza B, influenza A, and RSV, and other disease positive as well. So it means that during any such outbreak, we also need to have a very clear-cut laboratory prepared for not only AS, but also for the respiratory infection to be prepared. Based on all these information, we have prepared a algorithm that whenever there is a suspected case presented with either with the AS or RI, they should be first tested for Nipah TrueNet point of care. If it is positive, confirm at the Apex facility by PCR or by other method, sequencing method. And then if it is a negative, then it should be ruled out for the AS, RI, and other pathogens as well. In 2019, with the help of a high-level committee, we could make an algorithm for AS, and which include that what should be tested at Apex, what should be tested at district hospital. If it is if we screen for Nipah IgM initially, if it is a positive, then out of question. But if it is negative, then what other tests should be done? And that was actually defined and shared with the state to be taken care. So now the question comes then how we find out the source of infection. As I said, in earlier survey, we could see that Nipah was present in northeast area, which include Assam, West Bengal. But during this 2018 outbreak, we could reach during the outbreak, and we could collect the sample where the index case and other positive cases were there. And we could found the maximum presence of viremia in those bats, which was 25% bats were positive, not only in the rectal swab, but also in throat swab. But in 2019, similar kind of positivity was observed. And then IgG positivity was also observed around 21%. In 21, we could see Pteropus bats positivity. But in 21, we also saw that Raucetus bats were positive too for IgG antibody. In 23 outbreak, further we see Pteropus high percent of positivity for IgG antibody in Kerala state. As soon as the clustering of cases were reported, there was a deployment of the team was done from ICMR, NIV, NIE, and also the BAT team was deployed there with this new infrastructure of mobile BSL-3, which was stationed in GMC Kozhikode. And GMC Kozhikode team worked with ICMR, NIV, and this facility was built and it was validated. It was deployed in many field area, including before this outbreak, it was sent to twice to Kerala. We collected the BAT specimen. They were the drill was made to see that if it can be applied in an outbreak setting, and it worked very fine. When this outbreak happened, quickly this mobile BSL-3 was deployed, and other samples were handled on site in GMC Kozhikode to test the suspected cases. So now, if we talk about the genomic characterization of Nipah virus, the earlier sequences of 2001 and 2007 from West Bengal, they go and match very much to the Bangladesh strain. As John was telling, that Bangladesh has multiple genotypes present there, and which you can see that Bangladesh 1 and 2, which also match with the Thailand. But the sequences from Kerala, from bats and also from human, make a separate genotype, which is having around 3% difference, and they make a separate clot. But the present real-time PCR is still work for all these kind of samples, either from Bangladesh, Malaysia, or India. So the test is still very fine with all these genotypes. We started a countrywide survey in 2019 using all the assay which we developed. And we could demonstrate that not only the Northeast are Kerala, but there are other part of the country too, where not only the IgG antibody is present, but also viral RNA is positive in these bats. So, so definitely there is a high seropositivity seen in country, but these are just representative sampling. We have to do more to understand more details and also to understand more about ecology, as Kadambari has explained, that not only the bats, but human behavior is also part of these outbreaks. And every 2 years, there is just one single episode, but we do not know in other areas, in other states, if we are missing such cases, because it could be just one single case as well. So when we talk about the One Health approach in an outbreak of Nipah, Ebola, or of any high-risk pathogen, the quick diagnosis, contact tracing and isolation of high-risk contacts, establishment of on-site field diagnostic capacity building, and also the augmentation of laboratory testing, having a very good surveillance, which include all the factors, include bats, pigs, human, and other human behavior should be come in the picture to understand how this disease is happening, to understand better. And each outbreak, I must appreciate and I thank that state government of Kerala and different stakeholders, they participated equally with the same enthusiastic to come with the best finding and to the containment of the outbreak. The learning from COVID pandemic had taught more to work together, and One Health approach is the only way to do this. Thank you very much. If there is any question, I would like to answer. Thank you.
Thank you, Dr. Pragya, for your very nice talk on highlighting the response during various Nipah virus outbreak from ICMR as well as NIV. And also, you spoke of very critical aspects of improved diagnostics and response towards Nipah virus disease. Thank you very much for your talk. I would now move on to the next speaker, Dr. Manikam. Dr. Manikam is a senior scientist at the ICMR National Institute of Epidemiology at Chennai, India. And he actually shoulders a very heavy responsibility of managing the online courses as well as the in-house courses at ICMR NIE, National Institute of Epidemiology, on various public health issues. And he has a deep interest. He's a public health epidemiologist with core interest in areas of capacity building related to public health, outbreak science, surveillance and response to public health emergencies, and clinical research in traditional medicine. So over to you, Dr. Manikam. We look forward to your excellent talk.
Thank you, madam. I hope you can hear me and slides are visible. Thank you, everyone. The objective of this presentation is to provide an overview of what we know from the outbreaks of Nipah virus in India. As on today, India reported 6 outbreaks, including the most recent one in September. The number of cases in these outbreaks ranged from single case in 2 instances and to a maximum of 66 cases in the first ever outbreak that was reported from Siliguri in West Bengal in India in 2001. Based on the information available and also our involvement in 2 of the outbreaks, I'll be presenting what we have learned so far. In the 2001 outbreak, which occurred in a place called Siliguri in West Bengal state of Eastern India, there were 66 cases of acute febrile encephalitis reported from mainly 4 hospitals. There were 45 of them who died, and most of these cases were confined to hospitalized patients, family contacts of these patients, and then medical staff from these 4 hospitals where this outbreak was clustered around. Therefore, this outbreak with 45 deaths of 66 cases had a case fatality of almost 70%. This outbreak was retrospectively confirmed as Nipah virus due to Nipah virus few years later. The second cluster of Nipah outbreak of 5 cases of acute encephalitis was reported from West Bengal again, but this time in a village in Nadia district of West Bengal in 2007. This outbreak was described as a intrafamilial outbreak involving 4 family members and 1 health worker. All of them died within a matter of few days. The index case patient, which is case patient 1, a 35-year-old gentleman, a farmer, was reportedly addicted to a country liquor derived from palm juice. Again, this evidence is anecdotal. Almost a decade later, a 3rd outbreak of Nipah virus infection was reported in Kozhikode district of Kerala in South India, which was eloquently described by Dr. Anoop, how it started. This episode started with an index case, a probable Nipah infection virus patient, led to development of 19 primary cases and a few secondary cases as well. Most of them among his contacts, family contacts, and medical staff. Of the 23 cases, 21 of them died, a case fatality of almost 91%. The sequence of transmission, as was already described by Dr. Anoop and shown here, involved mostly nosocomial transmission person to person during hospitalization among contacts of the initial case. The median age in this episode was about 45 years, and the case fatality was, as described earlier, 91%, and majority of them were female. The median incubation period was 9 days, 9.5 days, which ranged from interquartal range from 6 to 14 days. Interestingly, the secondary attack rate ranged in a few of the settings, hospital settings, from 10% to 40%. Clinical features were already described at Anoop, but just to sum up, between Siliguri and Kerala episodes, fever was there, and altered sensorium with confusion and then followed by seizures were very common. And then almost both the episodes, Kerala episode in 2018 and Siliguri episode in 2001, had acute respiratory involvement, including ARDS. We earlier mentioned that there was these 2 instances of single case episode reported from Kerala, one in 2019 and one in 2021. This 4th and 5th cluster of Nipah virus disease, interestingly, one in 2019 was in a 21-year-old male in Ernakulam in Kerala who fully survived with supportive care. And the second one in 2021 in Kozhikode in a 12-year-old male child presented with a fever and late onset encephalitis and subsequently died. These were the 2 instances of single case of Nipah. The most recent one, 2023, was reported in September. The Kozhikode district surveillance unit in Kerala state in South India notified occurrence of acute respiratory illness among 3 residents, of which 2 belong to single family. The physicians, which included Dr. Anoop, identified that a family member, 47-year-old male, had earlier died on 30th August in another hospital due to hospitalization for severe respiratory and acute neurological manifestation. The hospital, which belonged to Dr. Anoop, where Dr. Anoop is working, tracked the stored throat specimen of the patient and tested positive for NIV on 15th September by ICMR National Institute of Virology. Therefore, this outbreak, interestingly, is the first outbreak in which the primary case was lab confirmed. Subsequently, 3 primary cases were reported among hospital contacts were identified in another hospital. In the 6th episode of Nipah virus outbreak, with 2 deaths, case fatality was little over 30%, and the secondary attack rate was 1.2%. With a descriptive epidemiology account from all the episodes so far, in 2018 outbreak, we had an opportunity, our team had an opportunity to work with the Kerala team to do a case control study among cases and controls to examine the hypothesis of human-to-human transmission circumstances. We compared 18 cases with that of 72 controls. We had 2 types of controls, a hospital group of controls and a community-based controls. We collected data on what are all the various circumstances, type of frequency of nature of contact with case patient. We could identify that contact with saliva of the case, being present in the same room as that of the case, contact of more than 24 hours in the hospital, in a hospital where Nipah patient was taken care of, were identified as risk factors. In community controls, we could not identify any of the above 3 risk factors as risk factors. As mentioned by Dr. Pragya earlier, subclinical infection was of interest to us. This was documented in Malaysia and Singapore, which was already known in the literature. Subclinical infection was never reported from Bangladesh. Therefore, in the 2018 episode, we examined whether asymptomatic Nipah virus infection do exist or not. We did a sero survey among 279 contacts, 155 health staff, and 124 household or community contacts. These are close contacts. We identified 3 with seropositivity, with a seropositivity percentage of 1%, confidence interval of 0.231%. All of them had a history of exposure to, all 3 had history of exposure to body fluids of more than 1 Nipah virus case. Of the 3, 2 were household contacts, 1 was health staff. 2 had IgM and 1 had both IgM and IgG positive. None of them had history of febrile illness after probable exposure. The treatment aspect, as has been already described very clearly by Dr. Anoop and others, John. In the 2018 episode, ribavirin was empirically tried in 6 patients, and then 2 survived. All the 6 patients who did not receive ribavirin succumbed to disease. From the ICMR side, we were ready with monoclonal antibody administration, with all the protocols and training completed in place. But then, however, we could not implement, because by the time the whole thing was ready, the outbreak was over. In 2023, as described by Dr. Anoop, remdesivir added to the treatment protocol, and the latest protocol of Government of Kerala talks about remdesivir for both exposed individuals and for post-exposure prophylaxis as well. What do we know so far on the basis of these outbreaks in India? We know that the outbreaks were reported primarily from 2 states of India. The cases were from all age groups, predominantly male and near fatal in nature. Clinically, the presentation was acute neurological and severe respiratory manifestations, mostly 1 spillover from non-human source with subsequent human-to-human transmission. Subclinical entity was infrequent, and person-to-person transmission was documented to be due to close contact or handling of fluids of NIV patients. And what do we do not know? We do not know how and why spillovers occur. We do not know the effectiveness of interventions so far implemented. In order to know more information is needed so that we can effectively either predict or control in response to Nipah outbreaks. What do we need to know? We need to know what are the areas or population at risk for identifying study areas or participants, which Nipah virus areas are at risk of transmission. We need to know the risk assessment being done considering the background risk of distribution of fruit by bats, evidence of Nipah virus in bats, previous outbreaks of Nipah virus infection, and high-risk behavior among humans. This can guide us in terms of where to go and which population to be focused for Nipah virus transmission risk. The second, we need to detect suspected or confirmed Nipah virus cases. We can rely on either routine surveillance systems, or we can have event-based surveillance systems constituted through special efforts in some areas. We can also think about community-based surveillance or facility-based surveillance. What we have learned so far is detection of second generation seemed practical. Therefore, we have to focus on them. Natural history of Nipah virus disease can be understood if we have a good investigation of these events or clusters using protocols. We need to profile the contacts as well. All this is possible through standardized protocols that are available. Kerala government, Kerala health system, Kerala private hospitals network have shown the way. An example is available in this country, and we can move forward to document Nipah virus more systematically and do good job in Nipah virus outbreaks. Thanks to all the stakeholders for providing this valuable information on epidemiology of Nipah in India. Thank you.
Many thanks, sir. Dr. Manikim, for walking us through the outbreak investigations and for describing how the knowledge and practices need to be found out and what next also needs to be done. I would again like to thank all the participants and the speakers. There are a couple of questions that have come in from our audience that I think we can have 1 or 2 questions for each speaker, if possible. So I would like to start with Dr. John Epstein. Sir, if you could come online. Yeah, please.
Hello.
Yes. One question that has come in is, you have studied the outbreak in Bangladesh, and in India it is spread in Kerala, that is far from Bangladesh. Do you see any correlation with the ecology of bats or the environment, sir?
That's an excellent question. I think early on in the process, when human cases were starting to be recognized in Kerala, there was a question about whether perhaps, infected bats had flown all this distance from Bangladesh, but to seed outbreaks in Kerala. But I think what we're seeing now, and it's quite clear, is that we should think of Pteropus medius as a continuous metapopulation, that these populations of bats are connected with each other. They're capable of flying, 60 kilometers a night in their foraging activities and hundreds of kilometers as they migrate from location to location or disperse. And so it isn't that, infected bats with Nipah have moved into southern India. They've been there all along. And as Pragya really eloquently showed, we're seeing evidence of circulation really in Pteropus across, and other bats potentially, across India as well. And so we should consider that anywhere there are Pteropus colonies, they're probably harboring some version of Nipah virus, and also to emphasize that this virus is pretty benign in these bats. This is a bat virus that's co-evolved with them over time, and so it's really only when it jumps into livestock or people that it causes real harm. And so we do need to find a way to both recognize that these bats are common and that Nipah virus probably circulates broadly, but without creating any kind of fear or panic about the potential for it to cause outbreaks, but rather just examine the way that we're coming into contact. And I think the points that have been raised by several speakers are critical, that in the Kerala context, we don't yet understand how spillover occurred into those index cases in any of the outbreaks that have happened. And so really trying to understand what the context is. Date palm sap harvesting seems more prevalent in West Bengal and Bangladesh in that environmental context rather than in southern India, but dropped fruit, they may very well be one potential route of spillover. But this is only really understood by being able to talk to cases, which is difficult when the index cases die before you can really interview them, but understanding from families and communities how people might come into contact with excreta from Pteropus bats. And so once we understand that, we can start to understand more of the ecological context by which people and livestock and bats are interacting. And it may very well be very different in different parts of India because the environment varies so greatly over the large country. Thank you.
Thank you, John. There was another question for Dr. Montgomery. Considering the robust surveillance network in the US and we have set up in Bangladesh, it is requested that more information, if it can be shared, on the intersection between labs, diagnostic, and frontline healthcare workers or the acute care workers. Are there focused trainings for clinicians in Bangladesh that the US CDC does? What happens when somebody suspects a new presentation?
Yeah, thanks. A really good question as well. And I think Pragya touched on some of this, but there has been, as I mentioned at the top of my presentation, the inclusion of a 24/7 hotline that has really enhanced the ability to rapidly detect cases. The question about clinical training, it's actually a key question and a key discussion point, beyond the kind of routine and standard surveillance has been described by some of the previous speakers. Clinician awareness is really going to be key to success for rapid detection. as Anoop has clearly described in his presentation. It really is the clinical awareness, the clinical training, and the clinical surveillance is going to be important. John mentioned too in his response to his question, there certainly is more widespread transmission than we're appreciating in India and in Bangladesh and in other Southeast Asian countries as well. In fact, I gave a talk just last week to colleagues to the Philippines Ministry of Health. I honestly think it's just a lack of surveillance and a lack of clinician awareness. I did talk a little bit about the clinical presentation, and as has some of the other speakers have talked about clinical presentation of this encephalitic phase versus a respiratory phase. I think we're missing a lot of cases that are mild or asymptomatic in the respiratory phase that one either never progressed to encephalitic phase or two progress to encephalitic phase and then unfortunately die without seeking any care or treatment. So I suspect we are missing a lot of cases in various countries where we know bats are, where the reservoirs are, and there's just no surveillance. But again, clinician awareness is going to be key, I think, in detecting some of these cases earlier in their course of illness, which gets to, and apologies for going long on this question, but it gets to the clinical care and treatment. Rapid detection early in the course of illness is, again, going to be key to reduction of mortality, either by providing just routine supportive care like ventilation, or once we have therapeutics that have been further refined or developed, applying these therapeutics early in the course of illness are going to be really essential. So clinical training is critical, and early detection and early awareness is critical.
Thank you, Captain Montgomery. We will look forward to your cooperation and also CDC India's work, and along with our clinicians, to set up a robust surveillance system here in India to going ahead. Thank you. Now, I think the question posed here is to Dr. Kadambari. So one of our audience wants to know if you think there is spread between different species of bats itself, and if so, do you think more bats are going to have it in the future, and how to track this spillover from bats to human beings? Right.
So there is a possibility of cross-species viral transmissibility, especially in cases where we see many species roosting together, which is quite common for insectivorous bats in particular. But in case of fruit bats, it seems unlikely from what we see in terms of their ecology and their roosting behavior. So it's probably unlikely that we will see cross-species spillover from, say, pteropus to other fruit bat species. But let's not rule out the possibility, because we don't know what exactly is going on. I'm just talking in terms of roosting behavior, but we don't know what happens during foraging, because they also tend to forage on these concentrated resources, especially in places like where you have a lot of fruit plantations. And it also depends on seasonality of these fruits. So depending on the availability of the resources, they tend to get concentrated, and there can be certain interactions that need to be tracked. And what was the second half of the question?
How do we go it forward if we want to hypothesize and do interventions on the interactions between humans and bats? What is the way forward?
Yeah, so as I mentioned in the presentation, there are various aspects to this, and there are many things that we need to track at both local scale as well as landscape scale. Things like deforestation and fragmentation of habitats is something that is critically going to affect fruit bat ecology and behavior, because as also Dr. Epstein also mentioned that they tend to roost near human settlements, and if the fragmentation is going to lead to them getting closer to humans, that's going to be something that we need to focus on. Along with that, at local scale, I think the first thing that we have to focus on is increasing awareness among people. Because generally there are multiple layers of all these factors coming together, and if we manage to basically just take care of one of the layers at least, there is a chance that the spillover might not occur. So we can't really do a lot of things at landscape scale in terms of quick troubleshooting, but we can look forward to manage certain things at local scales by increasing awareness at individual level, by having adaptive plantation management, which can help us avoid spillovers in the future.
Thank you, Dr. Gadamri.
Yeah.
Another question is for the clinicians. Dr. Anoop, the question here is, what is the guidance that is existing regarding quarantine and PPE for healthcare workers? I think this comes in the context of the first outbreak where we lost a healthcare worker, a nurse, in fact. And for people who are in close contact with potential Nipah cases, such as their family contacts.
We had the quarantine guidelines from 2018 onwards. So as you know, the average incubation period is from 4 to 21 days. So the quarantine period we kept at 21 days. So any persons who are exposed, we have to do the risk assessment based on the exposure. Then we'll have to keep them on quarantine for 21 days. So this time also we have identified all the healthcare workers also who are exposed, and we have kept them in quarantine. And I think the 2 cases were picked up from those people who were actually there in the contact list, including one healthcare worker.
Thank you, sir. And also I would like to inform there is a film called Virus that has actually been made on the first outbreak, right, sir?
Yes, yes.
That beautifully described how the back tracing was done, contact tracing, and virology aspects of it as well. I think, Pragya ma'am, there is a question for you. How can we leverage the survivors and their blood for further research? Is one question that has come up. Are there any survivors, and is there any monitoring or follow-up occurring with them at this time?
So yes, so from 2018 we have 2 survivor, and from 2019 also. So that 3 cases, and recently we have 4 cases. So in India, we have 7 survivors, and we are glad that they are doing fine health-wise, and they are being followed by state government time to time. So yes, they are on track. Regarding the research, the current research, which is most important for India, is to have monoclonal antibody, which can save when there is an emergency of such and patients are admitted in a hospital. So that is the one which we need to make effort. But at the same time, the CEPI, WHO, and as Dr. Joel was also presenting, there are many vaccine candidates in the place, and the most advanced vaccine is by Oro Pharma, where they have completed their phase 1, and they are trying to do a phase 2 in Bangladesh, and they're also talking to India. So I think if that trial can be done, or any of the vaccine candidate, because we know there are a lot of candidates available now, which can be good. So at least the high risk areas, high risk population can be such vaccines. And we know the healthcare worker are the one which is supposed to be given this vaccine. If there is a priority, we need to decide. So yes, and also the people who work in BSF4 facility on these dangerous pathogens. So that will be really helpful whenever we have such vaccines in the future. Thank you, Dr. Anoop.
Thank you, ma'am. And there is also one question for Dr. Manickam, sir. We have a question that is it possible to compare cases versus controls? That is the gist of the questions. People who have gotten Nipah and not gotten Nipah in the same environment. I think the AP gist is there any possibility to do a case control study between them?
And that is the only way we examine hypothesis. We can compare cases, confirmed cases, with that of those who do not have evidence of infection within the same setting. And that was what we did in 2018. Thank you.
I think one more study is currently on, sir, or being planned?
It's planned, and then it's under the active consideration of the Kerala government.
Thank you, sir. Thank you, everybody. Now my job is to offer thanks. So this is one of the first webinar series on One Health that the ICMR headquarters is planning with all the institutes and with all the departments. In fact, this is a novel initiative for all of us, but on the World One Health Day, we are actually proud to have brought all of us together with a varied group of speakers with such great experience and such great depth of knowledge. Let me first offer thanks to all the speakers. Thank you for giving us your valuable time. I know in the US it was a difficult period of time, and also for Dr. Pragya, Dr. Kadambari, and Dr. Anoop and Dr. Manikyam, it was very difficult to get out of your busy schedules and be available for the seminar. Many, many thanks to us. In fact, I can't thank you enough because it was a short notice and you actually accommodated our kind request gracefully. Many thanks for that. Next, I would like to thank Dr. Mayank, Dr. Meghna, Dr. Runa, and Dr. William at CDC India office, who are our collaborators and have helped us in putting this webinar series together. I would also like to thank the PSA office and the One Health mission and the Interministerial Action Group, of which India is a part and ICMR is a part. One Health is being taken up in a big way in India through all of its collaborating missions. And as Dr. Nivedita also mentioned, there is a National Institute of One Health, which would be a collaborative effort between all the ministries and all the sectors going ahead. So also I would like to thank all our viewers and people who have put up their questions on the screen. It was a very great experience having you and asking us questions. And thanks for all the love and affection that you have given us by attending this webinar. Thank you so much for joining us today. Thank you.
Thank you, everyone.
Thank you very much.
Thank you.
Thank you. Take care, everyone.
Take care.